first of all, I'm very pleased to welcome back Dr. Abonour, who's going to rabble-rouse in the area of bone disease. So welcome, Dr. Abonour.
Thank you. All right, good afternoon. So I have to get you ready for the most important talk in the day by Dr. Cole on the new advances in treating myeloma. But I think we need to stop and talk about bone disease, because I think bone disease is a very major complication of multiple myeloma. So obviously we have several problems that can happen, the low blood counts, the kidney dysfunction, but I think the bone damage continue to be a problem. It happens in about 85% of patients. And so the first thing that happens is that you may get holes in the bones. We call them lytic lesions. So imagine if you have a driveway and your weed or grass start growing in a driveway. So you have these holes in the driveway. That's where the myeloma cells like to grow, in these holes. But they also kind of weaken the bone, so they can cause osteoporosis. So between the holes and the osteoporosis, you have increased risk of fractures. And the fractures can happen in sort of weight-bearing areas, or in the ribs. You know, somebody tried to carry a big bag and twist it in the wrong way, or sneeze hard, you get broken ribs. Or you carry a big bag and all of a sudden, oh my gosh, my back hurts. You get a compression in the spine. So those are really serious, need to be addressed early and managed accurately, otherwise you'll get in trouble. Myeloma is a very old disease, and this is a skull from ancient Nubia, and you can see that there's these holes in the bones. On X-ray looks like these white round areas. That's what we look for. This can happen in the spine here. You can see several areas of the spine where it's involved. And when you get into trouble from that, you can actually not support the spine well, and some of that material will push on the spine, and you get what we call this cord compression. And that's a very serious problem because it can cause paralysis in addition to the severe pain. So that needs to be addressed. So why do we get into trouble with myeloma? Why do we get bone destruction? Because we have imbalanced bone production. We have too many of the cells that destroy bone, the osteoclast, and we have very few of the cells that build bone, osteoblast. A healthy bone requires a balance between osteoclast and osteoblast, building and destroying, so you can get a honeycomb-like structure. That's what our bones look like. That's why our bone is very strong. So too many osteoclasts and too few osteoblasts, and this is actually the problem with myeloma. So you can see here, the normal, when you destroy bone, you build it with the osteoblast. In the myeloma, you just destroy and you're not building, so you get weak bone. So, and what does that cause by? I showed you this slide earlier. It's just these myeloma cells produce things that stimulate the cells that destroy bone and inhibit the cells that build bone. So most of the treatment until now was to try to prevent these cells, we call them the osteoclast, from destroying the bone. Now we should hopefully start having something that will stimulate bone production, osteoblasts. We're still working on that. If you have too many of these factors that sort of, destroy bone, you're not going to do as well as if you have very few. And this is just a slide to show you that the people have very little bone destruction ongoing. They do much better. They live longer than people in the bottom here, where they have too many of the factors that produce cells that destroy bone. So it's actually also important in the survival of the patients. So how do we treat painful lesions? We have a lot of options, so we can sometimes use local radiation. Radiation actually is very, very powerful tool. It kills myeloma cells really quickly. You don't need a lot of treatment, 5, 10 sessions of radiation. Sometimes we do single session of radiation will be enough. And like any other cancer, if somebody recommend 20 sessions or more, that doesn't know myeloma. Go to a different radiation oncologist. The other thing is that we can do what we call kyphoplasty or vertebroplasty. I'll give you an example of that in a little bit. Finding a good surgeon, back surgeon, bone surgeon, specialized in cancer of the bone is really very important. Stabilization of the fracture area is very important. Pain medications, I think this is an area that in a long time, we were depending on narcotics. I think narcotics may help, but it's not the best drug for bone pain. Stabilization is important. Anti-inflammatory drugs are important, but the problem giving, ibuprofen, Aleve, naproxen, in addition to the steroid you take, you may cause, ulcers in the stomach, and also the ibuprofen, Aleve may affect the kidneys. So we try to be a little cautious with these things. Obviously, bisphosphonates are very important. We'll talk about that in a minute. So this is, sort of vertebroplasty and kyphoplasty. So basically, what you do is you try to build up the vertebra when it's sort of fractured. So you can stick a needle and put some cement in there, or a balloon, expand this vertebra, and then put some cement. So this gives you sort of immediate relief, and it's a very important procedure. You just have to make sure that the people doing it for the right reason, and consult with a neurosurgeon, specialize in the back, because sometimes it may not help, it may not be useful. So this is the two examples, the kyphoplasty and vertebroplasty. One is that you use, expand the vertebra and then put the cement, and then the other one is just put the cement in. So kyphoplasty is the one you use a balloon to expand the vertebra and then stabilize it. So this is just a radiation therapy. I told you already, it's very useful in controlling the disease, but too much radiation is not good because it can cause bone marrow suppression and weaken the immune system. The location of the bone lesions matter. I mean, obviously, if we have a lytic lesion in the skull, it doesn't matter, but here you can see this one in the femur. This is a big lesions. There's thinning of the bone. This will put the patient at risk of fracture. So bisphosphonate. How many people on Zometa or Aridia in this room? A lot of you, yes. That's good. That means your doctors have following the guidelines. These drugs inhibit the binding of these damaging osteoclasts to the bone, so you don't get destruction of your bones. So it's very important. It helps in lowering the calcium. If somebody has very high calcium on the presentation, Zometa or Aridia is very good drugs, and also help prevent bone destruction. We give it every 3 to 4 weeks, and it's Zometa. It's good. You don't have to stay there for a long time. About 30 minutes infusion. Aridia is 2 to 4 hours. So you need to monitor the patients during those treatments. So one of the things is kidney function. So patient who's receiving Zometa or Aridia, before you get the dose, you need to know your creatinine. Creatinine is a measure of your kidney function. If your kidney impaired, there are guidelines how much to use, or can you use it or not. So for example, if somebody creatinine clearance less than 30, that means you really can't get this drug. The other thing is that long-term exposure to bisphosphonate can lead to imbalance sort of between the osteoblast and osteoclast. You get sort of unhealthy bone, and you get this atypical fracture. Usually happens, as you see in this here picture, in the femur. This is very rare, but it's an important complication. The other complication that can be a problem, osteonecrosis of the jaw. Probably 15 years ago, we didn't understand it. We didn't know how to deal with it, and it was a big deal because everybody was doing more sort of intervention that needed. We know that the incidence of ONJ, osteonecrosis of the jaw, is about 3%, and basically it's manageable. What you need to do is before you get on these drugs, you need to have a dentist to look at your mouth, make sure that your teeth are healthy. If you need extraction, take care of that before you start these medications. Once you start these medications, you need to also stay in touch with your dentist and your doctors who's giving you the Zometa. You have to tell them if you have any area in your mouth where you feel like your bone is exposed, basically the gum tissue will sort of become thin, and there's some bone exposure. The problem with ONJ is that if you leave it alone and you don't pay attention to it, you may get an infection and makes things worse. So when I see a patient with starting with an ONJ, first of all, I stop the treatment with Zometa. I look at the area. If there is a sign of infection, I put them on antibiotics for about a month, and keep eye on them. And everybody will get better. So I always tell my patient, if you get an ONJ and it doesn't heal, I'll buy you dinner. And luckily, I have not bought any dinners yet. So we have evidence that this is very important. So the other new drug that people are excited about is denosumab, and that's got approved by the FDA recently. So it doesn't sort of activate osteoblast, but it does inhibit the generation of osteoclasts, the cells that destroy bone. So basically, that's where it works. So you're not making more osteoclasts. Bisphosphonate inhibit osteoclasts from binding to the bone. Denosumab prevent the generation of more osteoclasts. So it's been approved, and basically, it's a very important drug. So I'll show you some of the data. First of all, it's not inferior to Zometa. I mean, in terms of having events, breaking bone, needing radiation, having bone pain, Zometa and Xgeva or denosumab are about the same. And looks like overall survival also maybe about the same. But there was some hint, and this was not a primary endpoint of the study, that may actually delay progression to symptomatic myeloma. So maybe it has more anti-myeloma activity than Zometa, but we just don't know. The nice thing about it is that you don't have to worry about the kidney function to use this drug, Xgeva. You can use it in patients with renal dysfunction safely. However, you have to watch that they may have actually significant drop in the calcium. So if you are on this drug, you have to monitor your calcium. So when we give somebody Zometa, we check their creatinine. When we give somebody Xgeva, we should be checking their calcium that day. If you don't know your calcium, you shouldn't be getting it, because your calcium could be too low, 7, and all of a sudden it becomes 6, and you'll have symptoms related to the low calcium. So these are some of the safety data, and the majority of it is really related to the two things I told you. So, I mean, I think, the optimal therapy for bone disease is you have to get rid of the myeloma. That's a very good thing. Get rid of the excessive osteoclast. That's a good thing. And maybe have some activation of osteoblasts, the cells that build bone. So what are some of these things that are being investigated? DKK1, we worked on that. That's very interesting molecules. It has not been sort of moved forward, but I think really need to be studied again, because I think it can be useful. The other thing is that actually some of the, this is a drug that we try to study. The problem with this drug, first of all, I want to show you that this pathway, activin pathway, can induce osteoclast and reduce osteoblast. So this is just to show you that if you inhibit it, you get much healthier bone on the right than the one if you don't inhibit it. So we actually did some of that study that showed the bones can be really worked well, but we couldn't get this drug on to the market because it can increase red blood cells productions, and there was concern that we're going to have too many red blood cells around, and if you have too many red blood cells, you're going to have what we call, symptoms of hyperviscosity, clots, and things like that. So hopefully we'll find a better drug that we can bring that will help us build bone, because that's very important. The good news is that some of the drugs we use today may have some benefit. So bortezomib, for example, does reduce osteoclast activity and increase osteoblast. Same thing with Revlimid, may also reduce the production of osteoclasts. Though I think that's important. We need to address osteoporosis and osteopenia. I think it's very important that if you are a myeloma patient, you need to make sure that your vitamin D level is checked and is normal. When you're on bisphosphonate, you need to take calcium and vitamin D. You cannot just depend on the drug alone. So I think vitamin D is very important. Guess what? one of the best things for the bone is really walking. Weight-bearing exercise is very important. So do walk when you can. I'm sure when you have a severe back pain, it's very hard. But once your bone stabilizes and your back pain is less severe, I think walking 15, 20 minutes a day is very important. Again, vitamin D is important for the bone generation, important for the immune system. And you know, here in Florida, you're lucky you have enough sunshine. But if you live in the Midwest and things like that, you need to supplement your vitamin D, because it's very common. About 40% of myeloma patients are vitamin D deficient, and severe vitamin D deficiency is not a good thing, okay? So bone disease is a major cause of severe morbidity and increase the mortality in patients with myeloma. So new imaging study, I didn't talk about it, the MRI, the CT scan, whole body CT scan are very important to help us find these lesions. Sometimes we do bone density. I think it's very important to tell us if the patient has severe osteoporosis or not, and we need to consider using this drug in all patients requiring treatment, zoledronic acid or denacetinib.